To start this session with the introductory words of our director at PAHO, Dr. Teresa Tien. Doctor, you have the floor.
Good morning, good afternoon, and good evening. We have people from across the regions connected with us. Distinguished authorities and representatives of the Ministries of Health and other national institutions from the countries of Americas and from the other regions. Distinguished representatives of the United Nations and international cooperation agencies, civil society organizations representing Venezuelan migrants, ladies and gentlemen. I would like to welcome you all to the health sector event, Vaccination and Impact on COVID-19 on the Access of Refugees and Migrants from Venezuela to Essential Health Services. This forms part of the official program leading to the International Donors Conference in solidarity with the Venezuelan Refugees and Migrants that will be hosted in Canada, by Canada, I should say, on June 17, 2021. For decades, PAHO member states have prioritized the health of migrant and displaced populations, entering into arrangements for collaborative responses. You will recall that during the armed conflicts in Central America in the 1980s, for example, PAHO member states, under the banner of Health, a Bridge for Peace, emphasized, among other strategies, the need to protect displaced populations while providing quality health services to improve their health and living conditions. More recently, PAHO's 55th Directing Council that was held in 2016 adopted a policy document and a resolution on the health of migrants. Member states agreed to generate health policies and programs to address health inequities that affect migrants, to develop targeted interventions to reduce migrants' health risks, to improve regulatory and legal frameworks to address the specific health needs of migrants, individuals, their families, and groups, and to advance towards providing migrants with access to the same level of health services as other people living in the same territory, regardless of their migratory or legal status. Most of our member states have demonstrated their commitment and they have taken actions to provide health services to migrant populations. As part of the Interagency Coordination Platform for Refugees and Migrants from Venezuela, the regional health group that is led by PAHO and UNAIDS has promoted the coordination and the exchange of information between countries, partners, and civil society organizations to ensure that health interventions are implemented so migrants can have access to health services and public health programs, including COVID-19 vaccination in host countries. The COVID-19 pandemic has had a significant impact on the health of the people of the Americas, and among them, refugees and migrants. As of April 2021, surveillance systems in Brazil, Colombia, Ecuador, and Peru report a cumulative total of at least 38,000 positive cases of COVID-19 in refugees and migrants from Venezuela, including the deaths of some 549 people. Social and economic impacts of the pandemic have increased health inequalities, and this is well known. In this regard, strengthening the links between ministries of health and health groups on multi-sectoral national coordination platforms is important to identify and address the priority issues that require immediate, medium, and long-term attention. The three segments of this event, the experience of the Ministries of Health of Brazil, Colombia, and Chile, the perspectives of associations of Venezuelan migrants, and the strategies implemented by UNAIDS, PAHO, and UNICEF, and the IFRC will provide a balanced perspective for the deliberations of this health sector side event. Special thanks to Spain and the United Kingdom for joining PAHO to moderate the panels, which will provide critical inputs moving forward. And finally, I would like to acknowledge and to thank the generosity of the government and people of Canada in supporting the COVID-19 response in our region, and for its leadership in organizing this International Donors Conference in solidarity with Venezuelan refugees and migrants. Indeed, we all belong to the Americas family. And if one member of the family is suffering, all of us suffer together. It is solidarity and commitment that will bring us out of this pandemic. So I thank you again and look forward to your interventions. Over.
Thank you, Dr. Etienne. That was great. Thank you so much. Thank you for all the panelists, everybody who is showing their videos. At this point, I would like to ask all the panelists and moderators to activate your videos, please, so we can take a group photo, if that is possible. And also, we'll ask you to smile, okay? Okay. So I will give you a heads up. Smile. 1, 2, 3. Again. 1, 2, 3. Excellent. Thank you so much. Thanks a lot. So enough for review. Can I ask, then we have the first panel. Socorro, please, go ahead.
Sí, buenos días a todos los participantes.
Yes, good morning to all participants. Good morning, Dr. Etienne. Following Dr. Etienne's words, this is a very important panel, which also presents the experience of 3 countries, Chile, Colombia, and Brazil, in connection to access to priority healthcare services for Venezuelan migrants and access to vaccination. In all those countries, I'd like to quickly introduce our panel and then pass the floor to our first lecturer. The panel is made up by Engineer Maria Paz Grandol Saldoval, who heads the health public policies in the Ministry of Health in Chile, 15 years of professional work related to policies and programs of health and safeguarding that healthcare establishments are appropriate for attending to all people and particularly indigenous peoples. Our next panelist is then Dr. Luis Alexandre Osorio, Vice Minister of Public Health and Healthcare Services in the Ministry of Health and Social Protection of Colombia. He is a surgeon with a specialized in social security. And he has studies on health management and economy. He has long experience in health management and counseling on citizen participation in health. And then we have Dr. Tracy Medellin, veterinarian with experience in public health and field epidemiology at the Ministry of Health. Right now, she represents the Ministry of Health as a technical consultant for diseases transmitted by vectors, water, and others. So this is our panel, and I would pass the floor to Engineer Grandal. Please, Engineer, you have the floor. First of all, thank you very much for the invitation and for providing us this space to present our vision concerning vaccination, our strategy concerning vaccination. It's a pleasure, Carissa Ciro Socorro. Thank you very much. I'd first like to introduce to present and show you my screen. Yes, can you all see my screen? Very well, thank you very much. Well,
hasta el momento nosotros hemos recibido
to date, we received more than 17.9 million vaccines against COVID-19 from 3 labs. We have received vaccination from Sinovac, Pfizer, and AstraZeneca. We have administered to the population more than 9 million first doses and 7.5 million of second doses in a population of a total of 18 million inhabitants. This means 60% of first doses vaccination and 49% of second doses vaccination to our target population more than 18 years of age. I'm having a few problems with my presentation. Just a sec. Very well. Our vaccination calendar. Can you see the presentation? Yes, we can see it. We see a large and a small slide. Well, within our vaccination calendar, we have prioritized target group vaccination. Right now, it's pregnant women as from 16 weeks of pregnancy and people with comorbidities, heart, obesity, kidneys, immunodeficiencies, both acquired and congenital, Down syndrome patients and others, all of more than 18 years of age. We have prioritized according to how critical the population's problems are, and also for chronic people with chronic problems. And then we started with general population, and today we're vaccinating people between 30 and 34 years of age. Evidently, we continue vaccinating people who were not vaccinated before in pregnant women as from week 16. According to evidence, we can administer the Pfizer vaccine for them. Well, concerning
no me deja.
Just a sec, please.
Ahí está.
Okay.
Respecto al
Here we are.
acceso
Concerning access to health for migrants, our law today points out that the right to access to health is for everybody, resident foreigners or those who are irregular migrants, whether they are title holders or depending from their families, according to any requirements in our established health care. So we'll have egalitarian access to health. Concerning vaccination, the immunization department of the Ministry of Health points out that protecting people in Chile against immunopreventable relevant diseases for public health requires safety and efficacy according to scientific evidence. We have a lot of experience in vaccination, not only in COVID-19. We have a vaccination calendar for different target populations, from newborns to school vaccination, where we have diseases included as tuberculosis. In our calendar, we have hepatitis B, diphtheria, tetanus, whooping cough, poliomyelitis, hepatitis A, among other diseases. So we are delivering vaccination to all our population through a system that has functioned for many years in our national territory. So, concerning vaccination against COVID-19, we are vaccinating any population, Chilean resident, permanent resident, or visas of different kinds, or those who have requested a temporary visa or a definitive visa, and we exclude those who are only in transit with a tourist visa. The plan and strategy of vaccination covers all this migrant population in irregular situation who plans to stay in our national territory. Migrants can go and vaccinate according to our calendar for all the population. They can go of their own will. This calendar determines ages, particularly. We are vaccinating between 30 and 34 years of age, but there is no difference for any kind of population. So this is what I wanted to point out. And let us not forget that in promoting health, we promote the health of all the population, wearing masks, washing hands, and 1 meter social distancing. We have also included constant and necessary ventilation to be able to become protected against COVID-19. Thank you very much, and excuse me for my inconveniences during the presentation. Thank you very much, Engineer Grandon. I would pass the floor to Dr. Luis Alexander Moscoso Osorio, Vice Minister of Public Health at the Ministry of Health and Social Protection of Colombia. Please, you have the floor. Yes, good afternoon, Socorro, Etienne, and all the directors and dear colleagues, all ministers and government officials and other people who are with us today. I would thank you if you can pass my presentation. We'll be talking about attending migrant population in Colombia. It's a very important issue because they participate very much in our general population. Can you upload my presentation, please? Yeah, thank you. Next one, please. It's very important in our general population. Next one, please. Right, to see that we have since 2014, in which we had 23,500 people as migrants, to those who are with us in 2021. It's 1,742,000 people distributed into population groups. Some got in the country regularly with permits and authorizations, and that's close to 760,000, and those who came in irregularly in the country, and they are 943,000. The first ones represent something like 3% of our population. So our participation and the number of people who live in our country in a migrant condition is very important. But besides those who live in the country, we have around 5 million people who are pendular. What does this mean? It means that they oscillate. They come in and go out of the country regularly. This is a very important condition because that means 10% of the Colombian population. So the impact migration has in our country is very high. Next one, please. How are they distributed? Well, the migrant population is distributed all over the country. And 2% correspond to natural migrant population, and that's why they are more present in our borders with Venezuela. But they are scattered all over the territory. Next one, please. I'll make a description of the evolution of this pandemic in Colombia. This pandemic started with 3 peaks. The first one was in July last year because of the opening we had. We had a second peak related to Christmas and New Year, very high. And this was in an economy that is generally very active. And we are in the third peak of this pandemic, a longer one, which started after Easter, and it extended to mid-April. And then it started to come down, as we can see in the number of cases, but unfortunately, we don't see in the number of people who lose their lives. And we still have a high occupation of our ICUs. So what's the behavior of foreign people? Next one, please. Foreign people has a very important characteristic. They are young, generally speaking. Most of them are young people, as you can see, and this is why their behavior has been different from the general behavior in the country. And this is where we can see that although Dr. Etienne said that almost 38,000 people have shown COVID in the Americas, most of these cases were in Colombia. We have 474 who died and 32,604 people who got recovered. And they are 1.17% cases of the country, almost half the general rate of our population. And this is due to the fact that they are much younger than the general population in Colombia. 57% of these infections have been between people among people between 20 and 39 years of age, and they are mostly mild cases. Deaths and cases related to location is shown here, mostly in Bogota, with more people living in migrant condition. This is the behavior of cases and how they lost their lives. It has been very similar as the behavior in the country, with a peak in July, December, and now in the current peak that is longer. But thanks to vaccination efforts in the country, we have less death as compared to the number of cases. What has been the response of Colombia and the country in general to the migrant population? We have National Migration and Health Observatory that has to do with public policies, regulations, violence, and injuries, healthcare situation, health access, and population characterization. There, we establish healthcare services and attention to that 1,700,000 people, whether they have entered the country regularly or not. This is the evolution. In 2020, for example, we had 4,340,225 people attended. Likewise, migrants have services in 2 ways. Those that are regularly affiliated in the country and they have the right to the Social Security system, if they work through the contributive system, and if they do not through subsidies, and those that are irregular migrants also have urgencies and direct services all over the country. And as from this year, they have a temporary protection status, and they can become regular and have access to all the social security system as any Colombian. And this is very important. Of course, the people who are migrants receive health care, including vaccination programs, regular vaccination programs, like 728,000 doses to migrant population last year. Concerning healthcare services, it's mostly young women, and that has a lot to do with pregnancy and their fertility period also. The important reasons for this is that we have many women in our country, and they have received hospitalization and emergency services also for other kinds of procedures. This is a service to this population, almost 10 million, and we have attended to 1,113,550 people, a very important coverage for all groups, particularly boys and girls. 44% of attention provided to them, care provided to them, and women 21%, and we also have elderly people, 2.4% of these services. Next one, resources. These are the resources that have been applied to this care. Some more than $11 million, and total billing corresponds to $250 million. That's almost 900 million Colombian pesos. This is a very big effort of our government to attend to this population, and we invite all countries to support this process, a very important process, because Colombia is a country that has limited resources, so we need help. It's not a problem also for Colombia, it's a problem for all the Americas and even the world. Well, migrant population, Venezuelans who regularly come to the country have the right to social insurance. This is 759,000 people. 354,000 have already been affiliated, 185,000 who work, and 168 who are subsidized through the subsidized public subsidized regime. And that's 47% of all the regular population. We have more and more people in both regimes. About vaccination, this is the national vaccination plan. For migrants, it's not a new process in Colombia. It has been structured a long time, and migrants have the same rights to vaccination as Colombians. They participate in the national vaccination scheme, including vaccination against COVID. In Colombia, we started in mid-February, and we are vaccinating by stages. Over 80 years of age, 90% are vaccinated. Healthcare personnel in the first response line, but then 70 to 60 people. There we have a coverage above 65%, which includes the second line, the healthcare personnel. So among our medical personnel, we have more than 95% people vaccinated. Now we're opening the third line, 50 to 59 years of age, people with have comorbidities related to COVID, and also people who are strategic for the country, like teachers, and healthcare, children care in daycare services, police, army, and so on. This is the third stage that is just starting, and we hope it will last 2 months, this month and June. And it's particularly for, and I'm sorry, particularly for Venezuelans. They have the right in the same conditions and the same stages as our national population. We have applied first doses to 1,452 people, second doses to 612, and 2,064 total doses. Remember that they are mostly young. This is why they haven't reached their vaccination stage. This is the national vaccination scheme, as I commented in Colombia. It's not new for migrant population, particularly for Venezuelans. We have applied vaccines up to 1,500,000 vaccines, investing 38 billion Colombian pesos along these years. And finally, this is the temporary status that protects the Venezuelan migrants. It's an exceptional law by President Duque. The objective is to provide protection to all these people who entered the country irregularly. It's a temporary regime. They have temporary protection. For those who did not get regularly, they have this status for 10 years, and they are authorized to exercise any occupation or legal occupation or activity, and they have access to the general social security system in the contributive regime or in the subsidized regime. And they also have the right to retirement benefits and other state benefits. Well, in a nutshell. Next one, please. Colombia does not discriminate between migrant population and national population. They have the right to the same healthcare services, the same vaccination coverage, and the same vaccination conditions for COVID too. They have the right to the same healthcare against COVID, no matter if they are affiliated to Social Security or not, through healthcare by different healthcare providers. And they have the right to affiliate in the temporary protection status that guarantees healthcare to all migrants. That is 1,700,000 people who are in our country, 5.3% of our population, with a big resource investment, more than $300 million. So we invite all countries to help Colombia in this very big effort to provide care to all this population. Thank you very much. Thank you very much, Vice Minister. And now I'll pass the floor to the participant who represents the Brazilian program. And this is Dr. JC. She will introduce Ms. Ponte Lucena, who is the coordinator of the immunization program in healthcare and health vigilance. She has a lot of experience at municipal, state, and federal level. So, Madam, you have the floor. At the end of this, we'll have questions and answers. And the people participating here can ask questions to our panelists through the chat. So, Madam, you have the floor.
Brasil tiene el micrófono.
Agora sim.
Escuchamos, sí, adelante, por favor.
Então, bom dia, doutora Socorro, bom dia a todos. Quero agradecer o convite.
Good morning. I would like to thank for the invitation of the ministry, and I would like to share the vaccination program and what is the strategy we take with the migrants. If you are looking to my screen. So this is the program of health and protection of the refugees and migrants. And to give you a context about our plan, operational plan against COVID-19, the vaccine of COVID, based on the recommendation of WHO and what we implemented at a national level on the country. And this is the regulation that is published in our country. We established a definition of our priority groups, define our main groups. So we started with the healthcare providers, trying to protect those individuals that have the higher risk to reduce the rate of severe diseases and death. And based on those criteria, we define our priority groups, people of advanced ages, elderly people, together with healthcare professionals, especially as the ones that are in close contact with cases. So here we have some data about the applied doses on your left, vaccinated people on the central number, and vaccinated people with the 2 doses of the vaccines that we are applying. So we have 17 million people vaccinated on those priority groups. Here we have the data about the applied doses per priority group in the national campaign with doses 1 and doses 2 in blue and red respectively. So we see here the healthcare professionals, people from 65 to 69 years of age, people from 70 to 79, people of 60 to 69, people above 80 years of age. And in the low priority, we have the public transportation staff, education professionals that we are going to include in the next stage. So this is the operation that we incorporated, the operation inclusion, to also incorporate those high-risk populations that are considered the migrants. So especially here in the town of Boa Vista, where we have a close contact with migrants from Venezuela that come from Pacaraima, that is the entry site for our border with Venezuela. And here we adopted this process of prioritization for the entire country, but we established our priority plan on Pacaraima to prioritize the vaccination on those risk populations in that high risk area we consider it is with the city that have contact with the border. We included here 4,000 inhabitants per day during the first weeks. And during this period of action, Formally, we were able to identify 265,000 refugees and migrants from Venezuela that arrived to Brazil. So together with other entities that you can see here on the screen, with those cooperations, we work with different organizations, institutions that work together with us to guarantee the access of the vaccines for these populations at risk. And the armed forces as well supported us to identify and support those individuals, those Venezuelans that are now living in our country. So here we have some data about the people that were involved in our program. 51,735 individuals that were identified getting into the border. And among this action plan, we have different axes of work that are the reception of these people that arrive to Macaraima. Then we issue the formal documentation so we can identify them as adopted individuals into our civil registration system. Then we proceed with the vaccination, and then we provide shelter. So it's a provisional shelter for them so they could then be a part of the system. And during this process, some of these individuals were interiorized because they crossed the border to go to find their relatives in other states. So we supported them with solidarity flights to transport them into the states where they wanted to find their relatives. So the preparation for the response to the operation in front of the COVID-19 pandemic was the organization of protocols to support cases, the adoption of prevention protocols and control of the dissemination of COVID-19, implementation of the provisionally shelter and basic healthcare, a campaign hospital near the border in the city of Paracaima, the availability of supplies and diagnostic tests, and the articulation with other assistential services that are available on the municipal government. So of course, we use all these approaches into the Operation Acolida, that is the way that we designated this plan, and from that, we provide this solidarity care with these people, especially in the working in collaboration with the Ministry of the State. So the Operation Acolida was part of this state of Coraima. Here we have some data about the absolute numbers of interactions with Venezuelan migrants with the regional government of Guyana, that is the state that is in the border with Venezuela, with the number of hospital admissions that was reduced on the 2021 due to the campaign on vaccination, because the peak was the internal of the reception of new civilians was during the 2019 in the middle of the economic crisis of Venezuela, and we see how this absolute number of migration of Venezuelan in Roraima was reduced during 2020 and 2021. And here we have the absolute number of entry of Venezuelan migrants. Here we see in the district of Boa Vista in the blue bars, together with the admission of migrants in Pacaraima in yellow, and finally other municipal governments in purple. And we see how this trend increased at the end of 2019, and then they start significantly to become reduced. Here we have the main reason why they leave their countries from 2015 to 2021. And here we see that the main reason why they leave their towns is because they are pregnant and they wanted to deliver their babies into Brazil because their health care services in Venezuela are not guaranteed. The second reason is diseases of the respiratory apparatus and other causes of health conditions such as parasitary infections, and that's something that we see in the profiling of 2020 and 2021. And here we see the vaccination process from the operation Acolida. We see many health course where we receive these Venezuelan migrants to receive vaccines. So it was part of this internalization process to receive the vaccine so they could be part of the adoption of other state. And this is how they receive support. And that's why they were part of this process. And from there, the municipal of Pacaraima and Boa Vista support the availability of vaccination, the orientation of the technical orientation when they deserve it. So we have 48 health centers or vaccination centers that are there available to be orientated in terms of the vaccination process. So additionally from those actions, we have in the vaccination program for the Venezuelan. So we have this strategy of vaccination for the doses that we administered during the 2020 in the district of Boa Vista and Pacaraima, with not only for COVID-19, but also with other conditions that are needed to be supported, and other actions that are available for the. And here we have the individuals that received the vaccine under 15. And here we have some data about the doses that were applied, also with the Brazilians that have the interior process of doses applied in 2019 and 2020, together with the entire cycle of vaccines applied for the Venezuelan population living in Brazil. And as I mentioned before, we make available those vaccines independently from the fact that they are part or not of the health system. So here we have some of the number of doses applied for the Venezuelans, particularly in the city of Roraima, depending on the type of vaccine in 2019 and 2020. Here, for example, the rotavirus was 600 and 300. The smallpox was 12,849 versus 4,151. So this is something that we established as a vaccine doses, and we wanted to make those available in Roraima. So this is the first doses that we wanted to establish in the 400 doses, and this was part of the available doses. But in fact, that concept of vaccine for the country, in those priority groups, have access to vaccination to the vaccine to COVID. So here, in these presentations, the challenges that we confront, as you can see, was the closure of borders due to the high flux of entry, and we needed to reduce the risk of our individuals to become exposed to high-risk populations as migrants, but we wanted to provide a shelter for them, so we tried to provide one kind of interaction with the border authorities with the other part of the border. And here is something that allowed us to increase the security of our individuals. And here the immunization process was part of this comprehensive approach to give a provisional solution to the refugees so they could have access to the first and the second doses in the municipal governments where they are living. And from there, the vaccination of the risk groups, not only because of the COVID-19 crisis, but also providing other vaccines that will depend on the access of public health entities that will be served as this with the same priority as the same access that will a Brazilian will have in our own borders. And from that moment, we look for this vaccination strategy to guarantee the health security of these migrants. So that was what I wanted to share with you. Thank you so much for your attention.
Obrigada. Licenciada Adriana, tener un espacio de preguntas y respuestas después de estas presentaciones.
We'll have a space for questions and answers after these presentations. We have seen the decision of the countries in the Americas about having vaccination and immunization as a public good. The people who live in our region and how important vaccination programs are, and also how vaccination against COVID-19 allows to strengthen immunization among migrant populations coming from Venezuela who are in these different territories. We have a question for engineer Brandon on Chile. Well, this question is how can irregular migrant people have access to vaccination? And you also answered this in the chat. Does this include healthcare professionals or professionals from other areas and programs aimed at vaccinating these migrant populations? You have the floor, engineer. Thank you very much. Thank you, Socorro. I'm very glad to answer to these questions. In our healthcare public system, you only need a simple registration. It's called FONASA. You just provide your information. You say you're a migrant and you have the intention of staying in the country, and then you register. And this gives access to all kinds of public health, including vaccination. So there's no barrier to anyone, nationals and migrants who are in the national territory and who have no financial means to have access to private service can have access to the public service called FONASA. No matter what your migrant condition is, all have the right to health and therefore to vaccination. That's about the first question. Concerning the second question, if in our healthcare establishments we include migrant population, yes, of course we do. The health alert provides even more access to them because medical doctors in the country have to go through a test. Currently, because we are in a health alert, that test is not necessary. Therefore, all healthcare professionals who are migrants can work for different healthcare services, both public and private. Usually, our legislation expressly points out that in several national territories that are remote, you have no additional requirements for professionals from other countries to exercise their profession. Therefore, that's open for all healthcare professionals in Chile. Thank you very much, engineer. I pass the floor to Vice Minister of Health from Colombia. The question is if what you have presented also includes international cooperation interventions, and if in vaccination you include humanitarian personnel or personnel from other countries that are in the first line. Yes, of course. First of all, the people who are in Colombia and are not regular, the only document they have to show is an identity document where we can see their age so they can be vaccinated according to stage. And concerning access of healthcare personnel who are in migrant condition, if they are registered or have healthcare function, they have a priority. Concerning emergency services, they have to be derived by the IPS, depending on their nature, but the temporary protection system allows them to affiliate to the Colombian social security system. About first responders who attend to population, to migrant population, they are prioritized on the 4th stage, which opens in June. They can vaccinate then. And concerning reported information, we only have health care information, which does not include what international donors have provided. Thank you very much, Vice Minister. Last question to close this panel. We have Ms. Lucena, and in the same order, how can we include migrants in vaccination in shelters in Brazil?
Doutora, desculpa, contou pouco sua fala, a
vacinação. Sim, Adriana, tem incluído pessoal de saúde migrante nos programas de saúde e vacinação.
My question is if you included healthcare professionals that are migrants as well, if you included in the acolhimento program. Well, yes, we established strategies of vaccination within these individuals, independently from their condition or their professions, trying to provide a vaccination of quality in the country. Thank you so much for your answer.
Más preguntas que van a quedar en el.
We close here. There are more questions in the chat, but we have to close this panel. So we thank the 3 lecturers, particularly for a subject that is so relevant as vaccination, one of the most effective interventions in public health and in the regional effort of vaccination for all the population, no matter if they are migrants or not. Thank you very much, Vice Minister, Engineer, and our colleague, Lucena. Good morning to you all. Thank you very much to the first panel. So thank you very much to all representatives from Brazil, Chile, and Colombia for their presentation. We go to our first programmed video. It was produced by the Ministry of Health concerning inclusion of healthcare workers in the Peruvian healthcare system. We can pass the video. Thank you very much.
Mi nombre es Francia Alejandra Calvo Alseco, soy
Please
venezolana.
follow the English subtitles.
Bueno, cuando yo decidí migrar, que en principio no había sido como tal del todo mi voluntad, sino bueno, por situaciones en ese momento que me obligaron a salir de mi país, estuve evaluando varios países en donde posiblemente me pudiera ir y Perú era el país en donde había la menor cantidad de requisitos para la validación del título. De hecho, en esa ocasión era nada más el título legalizado apostillado y el documento de identidad vigente. No estar cerca de la familia no es fácil, pero bueno, sabes, una cosa como que compensa la otra. Pues por lo menos acá tengo la posibilidad de ejercer mi carrera, de que sea bien remunerada, de que yo pueda vivir tranquila. Y bueno, a pesar de no tener a mi familia cerca, más bien con la posibilidad de poder ayudarlo a ellos.
Con eso pudimos poco a poco salir adelante y reunir para lograr dar los exámenes y así poder colegiarnos aquí en el Perú como médicos, ¿no? Y poder ejercer. Me sentí dichosa, me sentí afortunada, me sentí bendecida por Dios porque a pesar de todo lo que estamos viviendo, de toda esta terrible enfermedad y de toda esta pandemia a nivel mundial, pues es una gran oportunidad para mí que me ha permitido crecer tanto personal como profesionalmente y obviamente para mí ha sido una gran oportunidad, ha abierto demasiadas puertas en mi camino.
Sí, ya yo estaba en el sistema de salud colegiado, estaba antes de la emergencia sanitaria. Ingresé a trabajar en centros policlínicos, clínicas durante, por decir, me colegié en diciembre y ya en enero ya yo tenía lo que era mi colegiatura. De enero a febrero, marzo aproximadamente trabajé en un centro privado y ya posterior a eso cae lo que es la pandemia, pues. En lo que cae la pandemia ya notifican que están buscando personal médico con sus papeles al día, colegiados para poder ingresar en el sistema del MINSA y por supuesto es una oportunidad sumamente grande que pude aceptar y la acepté pues. O sea, tomé el riesgo de poder salir a las calles, a salir al MINSA, a ayudar puerta a puerta en esos domicilios, en los equipos de respuesta rápida para salvar a la mayor cantidad de personas que lo ameritan y que en estos momentos todavía es así.
Muchas gracias. Continuamos con el segundo panel. Adriana Lucida, adelante, por favor.
Sí, muchísimas gracias,
We
Celso.
continue with the second panel, Adriana from UNAIDS. Thank you. My name is Adriana Ponte and I'm in charge of a humanitarian response from UNAIDS. We will have the first presentation on perceptions, vaccination against COVID-19. We thank all panelists and moderators. I'd like to remind those who have just become included that you can see your translation and Portuguese interpretation options that are available for you. So I'd like to pass the floor to Dr. Cristina Gutierrez, who's going to moderate this panel. Dr. Gutierrez directs the humanitarian office at the Spanish Cooperation Agency. She is a surgeon by the Valladolid University, and in 1994 she received the doctorate on parasitology from Barcelona University, and then she became an expert in this type of projects at the Complutense University. She has been general coordinator of Spanish cooperation in Morocco and Mozambique, the last responsibility she had before her current position of director of the humanitarian office, which she leads since September 2018. Thank you very much. You have the floor. Thank you very much to you all. A pleasure to greet all participants in this event on vaccination and impact of COVID-19 concerning access of Venezuelan migrants and refugees to healthcare services. In this panel, we'll talk about the point of view of migrants and refugees from Venezuela and different Latin American countries, and they have this perception concerning limitations to healthcare service, to access to healthcare services after this pandemic, and their perception concerning access to vaccination. We have three panelists who will talk about their experience.
De sus compatriotas venezolanos en distintos lugares.
The experiences of their partners in different areas, the Venezuelan coalition in Colombia from Venezuela, Adriana Rincon in Panama, and Oscar Perez, who coordinates the Venezuelan Union in Peru. The first panelist will be Juan Carlos Vilonia, who is the general coordinator of the Venezuelan coalition. He's a medical doctor. He has had 14 years of work in public work with medical public work with migrants. He is the leader in Barranquilla. He is a member of the focal point for Latin America and the Caribbean of the main group for infancy or childhood and youth. He is a member of Young Initiatives in the Americas, and he has gotten the National Award of Young Talents in Colombia. A pleasure, Juan Carlos, and you have the floor. Thank you very much, Doctor. Thank you very much for this presentation and greeting from the Federation Coalition for Venezuela. I'd like to greet my panelist colleagues and Oscar Perez from Peru and Adriana Rincon from Panama, dear colleagues and workers of the Coalition for Venezuela, Alejandra and Adriana. Thank you very much for this invitation, together with Celso and others from the from PAHO. As we saw in the first section of this forum, and this regional forum of the right to health care, at the Federation, we saw that we're the first population affected, but also part of the response together with governments and international organizations such as you. The right to health in Venezuela was very much deteriorated before the COVID-19 pandemic. The healthcare system in Venezuela was collapsed in different aspects and services. Our Venezuelan nationals, along all these years of crisis, have faced hard moments to access healthcare services. We have seen so because there is no access to epidemiological healthcare bulletins. And we now evidence that this is a limitation to know about what is the current state of public health in Venezuela. We need evidence concerning this socioeconomic and political impact of lack of information because we don't know how many children die or mothers die or nutrition, etc. Reports published by PAHO and WHO, the National the World Food Program, FAO, and other international organizations show there are many gaps to access the healthcare services, high demands in hospitals and clinics. And something very important I'd like to highlight are Venezuelan doctors, nurses, and healthcare professionals in Venezuela are under critical risk of getting sick and die because of the little coverage there is of COVID vaccination. And also their work conditions. They have had to flee with other inhabitants in our country seeking for better living conditions. In the former panel, we heard comments on how we can try to insert our Venezuelan brothers and sisters in the different territories, as well as the limiting factors such as the work conditions in Venezuela. They don't have inputs, instruments, facilities are deteriorated, and intensive care units in the country, as well as dialysis units and many other medical equipment necessary to cover demands and needs are collapsed. They do not exist or are defective and do not cover the number of cases that require our attention. This is why civil society organizations such as the Venezuelan Observatory for Health, also United Doctors in Venezuela, have published statistics on doctors, nurses, and other professionals who had to flee our country seeking for better conditions. More than 15,000 medical doctors left Venezuela. At the civil society, we have detailed work for knowing in which countries, what professions they are from and where they are. In the Coalition for Venezuela in Colombia, we have identified more than 2,000 healthcare professionals. In Peru, our colleague Oscar will talk about the effort made with local authorities and their organizations to make this population visible. Likewise, in other countries in the region. So I'd like to highlight that we have great human talent, which requires support and political will, not only those in these organizations, but also in governments and other organizations supporting this effort. Within the donor conference next month, we invite Canada and other countries to realize about human talent abroad to improve healthcare of our Venezuelan brothers and sisters. And this requires regularization. The Coalition for Venezuela had a high-level forum with different authorities to exchange ideas and experiences on how regularization is an engine for inclusion and development. In a civil society, we need to sit together with governments and other brethren organizations, tell you who we are, where we are, and what we are doing to establish the best public policies so Venezuelans can access to health. I'd like to highlight some efforts made by PAHO, such as technical cooperation to Venezuela and neighboring countries, since there weren't official channels for communication in many cases. Also, the effort made for the regional vaccination card that is regularizing our migrants of all ages in the immunization plan. We all know that Venezuela has gone through a great crisis of access to vaccines, not only to COVID, but to other diseases that were eradicated in our region and country before. Also highlight the access Venezuelans, migrants, and refugees inside and outside the countries require effective treatment against tuberculosis, HIV, malaria, cancer, and non-communicable diseases, chronic diseases. Also, our civil society should be able to find a way to coordinate with international organizations and hosting countries so we can tell you what needs we have concerning medical care, as well as the opportunities migration brings, not only to relate healthcare professionals to healthcare systems in each one of those countries and strengthen your response, because we have heard you need specialists, you need professionals, and also we can contribute, Venezuelans can contribute to respond to this crisis, and there are efforts made by several organizations. Medical doctors from Venezuela are in health care thanks to allies such as the Red Cross, the International Rescue Committee, the Siemens Foundation, and other allies that are now members of this platform as PAHO, UNAIDS, other partners. I'd like to thank on behalf of the Coalition for Venezuela, Tim and Philip, for coordinating the 4V platform, and also the healthcare coordinators, as well as the authorities that have opened these spaces to us. They're necessary, but we need to go beyond. We are about to have a very important donor conference, and we have a deficit in our response to healthcare problems in the region. So we need to strengthen healthcare systems, working on other areas, making sure that there is access to food, access to regular documents. And also, I'd like to underscore that in our current COVID-19 situation, governments need to make sure there is access for irregular migrants. There are still gaps for migrants and refugees who have an irregular status, have access to COVID-19 vaccination. It should be mandatory. Let's make a common, a joint call to country governments, private companies, and different kinds of agencies for our Venezuelan population. We can see progress and growth in our communities and receive these people, including them to host societies. This is how I finish my participation here, and I call all of you so that we can continue working together, evidencing these limitations concerning regularizing access to health, attending to migrant population, coordinating with organizations, migrant and refugee organizations. Governments can have access to all of this information, but there is a gap concerning irregular migrants and refugees. And we receive letters, messages, calls from these Venezuelans who can't have access to healthcare services. So through campaigns and solidarity of our support network, they can have access to medicine and procedures as we can, but we have to get to know more about the epidemiological profile of migrants and refugees in the region, strengthening healthcare services to respond to COVID-19. Thank you very much on behalf of our volunteer network. Thank you very much. Thank you very much. Now,
Rincón, que es
I pass the
coordinadora
floor to Adriana, who is the coordinator in Panama. She coordinates a journal, Activados. She is a mother, wife, and professional. She migrated to Panama 13 years ago. She founded the Venezuelan community newspaper there 13 years ago and started with the foundation activating the talent of Venezuelans towards integration. She's a social communicator. She has masters in management and psychoneural linguistics, planning, and NGO management. She integrates the Journalist Forum and participates in other organizations aiming at driving migrant rights. I remind all panelists that you have 5 minutes for their presentation. We're a bit delayed. So you have the floor, Adriana. Thank you very much. Thank you for this excellent panel and for giving us the opportunity of talking from our reality in different countries, what we see in terms of Venezuelan migration. These are not new words because in all these forums, we have talked about coordination sessions, assemblies. We talked about things that have to do with migrants and countries in the region. I'll talk about two fundamental topics. First of all, I need to share my screen. I'd like to show you something very brief. Well, this is the analysis of the healthcare situation in Panama. Panama devotes 3.3% of its national budget to health. Out of that, 4.2 million are for the Social Security, a system in which workers pay, and before the pandemic, 80% of migrants and refugees from Venezuela have no access to Social Security. Then $1.5 million go to MINSA, the Ministry of Health in Panama. They have a network of hospitals and healthcare services, and the Venezuelan migrant community does have access to that. Before the pandemic, they analyzed the healthcare situation and determined two fundamental things. I want to show them to you because this is a high-level forum and you can help. First of all, they recommend a study where we should talk about population characteristics to determine what area needs intervention to deal with inequalities in access to health. Also, they would like to leverage collaboration between international organizations and MINSA to strengthen national capacities in health. This is a work for all of us. This is a practical case, as you can see. I led 2 years ago. We had the American U.S. Comfort aid ship. We took our migrant population at 60 people per day. We had long lines, more than 1 kilometer. We had Venezuelans and Panamanians. They waited for 4 hours. There was a Panamanian person with hypertension problems, and we can see that Panamanians already have problems, even more so Venezuelans. So this is the day-to-day in our healthcare situation, both for Panamanians and Venezuelans. Despite this, the vaccination process in Panama has been totally inclusive as from day one. Their vaccination policy allowed migrants with passports that were current or not to participate. You see an old man receiving a vaccination here, and you can also see the person that has been erased here, and this is her document. She only has a passport and received an appointment for vaccination. Panama wants to vaccinate 3.1 million people out of 4.3 million people of population. 6.6% of people have already been vaccinated to date. More than 835,000 vaccines have been applied. The country does not offer separated statistics, and that's good. Our migrant, refugee, and foreign population, generally speaking, no matter what condition they have in the country, are part of a total and national total. No discrimination in appointments for vaccination. We have modern digitalized systems as the RISA process through WhatsApp, Telegram, or a web. Any migrant can have access to it. Any person, no matter what his or her condition, can have access to this and get an appointment. We are not discriminating migrants. That is from day one, February 12th, in which we open the system. It's open to all migrants. They have to be vaccinated according to age. This is something that we have applauded. It has been a positive piece of news in the local press. Elderly people have already received their vaccines, and that's very positive. I'd like to mention two good practices in Panama. It's not only for COVID-19 vaccination. Panama has never discriminated anyone concerning vaccination. Anyone with a passport or with any kind of document can have access to vaccination. It's also important to mention in meetings we had with different organizations is that Panama provides treatment for foreign population no matter what their migratory status is. They can have access to treatment against HIV. So 13 years in Panama. I'm Venezuelan and Panamanian now, and I can see what is the relationship with our migrants. In the case of vaccinations, thank you very much, Panama. These are people from our elderly Venezuelan elderly people. They have had access to vaccination. So from my point of view, we thank you very much, and we call international organizations to help Panama to overcome their gaps. As migrants, we also tell you that not only Venezuelans, but also Panamanians need health care attention. Thank you very much. Thank you very much, Adriana. I pass the floor to the last of our panelists, Oscar Perez. He has a management degree. He has been representative in Miranda and Caracas, and he currently chairs the Venezuelan Union in Peru. For 5 years, they have had projects and initiatives to integrate Venezuelans in Peru. You have 5 minutes. Good morning to you all. Juan Vilorio and Adriana Rincon have talked very well, and I greet you all as they did. Well, I talk in one of the most difficult moments that I am personally facing. My wife is sick. Obviously, with this, I am just evidencing how difficult it is for a Venezuelan migrant or refugee to have access, easy access to healthcare services, which were not planned in our baggage. I will read a few paragraphs I wrote so I make no mistakes. I start by saying that before the declaration of the emergency in Peru, official figures of the Statistics Institute show that 94.2% of Venezuelans are not affiliated to Social Security, and 66.8% of women do not use any family planning method, and we can see that 88.5% work informally. Their average income is $310 men and $207 women. This pandemic made their lives more difficult. They were fired of their jobs. It was difficult to send money to Venezuela, among others, that do not allow them to buy medicine or pay for healthcare services. This study by the National Statistics Institute of Peru shows that almost 50% of Venezuelans self-medicate themselves because they cannot have access to healthcare services. For the migrant and refugee population, getting sick is a luxury that we cannot afford. We acknowledge that the Peruvian government is giving access to retroviral medicines to our Venezuelan migrants. As from 2016, as has been stated in our country, there are no retrovirals in Venezuela. They are also protected against tuberculosis and malaria in Peru. However, it's necessary to implement supplementary programs aimed at this vulnerable population. At the beginning of the vaccination against COVID in Peru, we see that although public authorities that foreigners, even in irregular migratory condition, would be vaccinated. This did not happen at the beginning, and it generated uncertainty among migrants. We must acknowledge and thank publicly that then we started to see people being vaccinated. Foreigners over 70 years of age started to be vaccinated, no matter if they were in the registration list or not. And this vaccination is being carried out with no discrimination and without taking in consideration if they are regular or irregular migrants and refugees or general foreigners. So thanks to the effort of the government, United Nations, national and international organizations, migrant, refugee population, Venezuelan population in Peru are now being vaccinated. And we hope this policy will continue without problems. However, we have gaps concerning access to healthcare services for immigrants and refugees. One of the most important are that they are requested a resident card to be affiliated to the healthcare service. More than 50% of Venezuelans have not regularized their situation, so they don't have this document to have access to this healthcare system that subsidizes attendance in public healthcare service. More than 500,000 Venezuelans are requesting refugee status, but they have not gotten it yet. And because of migratory conditions imposed in 2019, they are entering this territory irregularly. We have a huge problem. We have to continue working so as to have most Venezuelans to become affiliated to any of the existing modalities of the integral healthcare service. We'd like to underscore something that very few people talk about and which is very important. Today, we want to particularly call your attention on mental health care. Venezuelan migrants and refugees have had a great impact, mental health impact that has been even worsened by this pandemic. We have many Venezuelans in Peru affected by this, and I'm sure that this happens in all the region. They face the sequels of migrating, plus all their adverse situations. So we are concerned about gender violence, suicidal trends we have seen in the recent months. So ladies and gentlemen, I call you all to face this other pandemic that is affecting us so much, the psychological pandemic. It is silent, it's invisible, but it causes many issues, and we consider it is fundamental, important, and necessary to implement more programs aimed at providing massive mental health care services to Venezuelan migrants. It is also relevant to go ahead with more effective communication policies so migrants and refugees get to know what healthcare services they have right to and what are the access routes to them. Oftentimes, lack of information is one of our main enemies. I said something at a meeting yesterday and I repeat it today. Many of our brothers and sisters leave our countries seeking access to healthcare services. Others just dignified places to die. In face of a tragedy we are still seeing in Venezuela. And as this was frankly said about what is happening in our country, we need to seek forums that will take real and practical solutions to this horrid drama in Venezuela. I'd like to highlight that more than 7,000 Venezuelan healthcare professionals are working as first responders facing COVID in Peru. And they could be many more if we didn't have so many obstacles that are not put by the Peruvian state, but by medical associations who do not want to see healthcare professionals included. This is a very difficult time for humankind and for Peru too. We cannot see nurses working on streets selling candy or cake as peddlers. How can we have specialists, medical doctors driving public transportation or as transportation collectors in Lima? How can we see medical doctors or psychologists working in shops at malls just because some medical association leaders who do not see in these professionals the possibility they should have to share their knowledge and experience and that can contribute in this very difficult time we are facing, not only Venezuelans, but humankind, generally speaking. I'd like to insist in the fact that we need to fight to open more spaces to work for mental health. I think this is something that is invisible, but which is causing very serious troubles in such difficult times. Thank you very much. Thank you very much to our three lecturers. We have had several questions in the chat. Some have already answered. So I'll ask others that when we go ahead with our panels, you respond. How do your organizations and initiatives participate to ensure access to healthcare services or sharing sharing information and access to information for Venezuelans? Thank you very much to the three of you. We have learned a lot with you. Now we close the panel and pass the floor to the following. Thank you very much, Cristina. Thank you very much to the three panelists who have talked about their experience in the different countries where they are carrying out work in favor of migrants and refugees from Venezuela. Now, I'd like to give the floor for a video that will show how migrants and refugees are catered for in Peru. I pass the floor for this video.
Mi nombre es Isora Pérez y estoy acá.
My name is Isora Pérez.
Al llegar acá a Perú,
when I arrived in Peru,
inconvenientes. Muchos de venezolanos quedaron
have many inconveniences. Many of them did not know how to where to sleep, where to stay. And this meant anguish and stress. The video is silenced now, I'm sorry, and it's choppy. I'll try to help you as much as I can. Well, there are flyers that we give to people. These flyers show them what to do. They talk about how tuberculosis is transmitted, for example. There are training or workshops by PAHO that have motivated several social leaders. This is Oscar Perez, who leads the Venezuelan Union in Peru. He is talking about psychosocial support here. And he is talking about the serious deficit Peru has concerning psychosocial care. So we need to start working in our communities so that we have community brigades that can help us with our own problems. This is the case of the psychosocial support program that also deals with HIV and tuberculosis among Venezuelans and Peru. We also have first aid and emergency programs for migrants in Peru. PAHO and Red Cross provided this training. The video has been stopped. Well, I think there were audio problems with this video. We'll try to solve that, but meanwhile, we'll pass the floor to the third panel. The third panel will start in a few moments. Well, we have the video again. My name is Isora Perez. I've been here for a year and a half. I realize that Venezuelans have some problems when they arrive in Peru. Many are homeless and they didn't know where to sleep, where to stay. They didn't have a fixed job, and that took them to depression and anguish. PAHO has also been helping the migrant community in the country. We were trained by Zoom, and we also got these flyers. They are given to people according to their different needs. They can have tuberculosis, for example, or HIV. So these PAHO training workshops have motivated several social leaders. This project comes from PAHO and the Venezuelan Union concerns about the urgent need for acting against the psychological pandemic too that occurs now. There is also this reality of a very serious deficit of psychology professionals in Peru. So we accepted the PAHO proposals about starting to work to prepare, train community leaders who can act in brigades for psychological first aid. This is the psychological support program, also dealing with tuberculosis and HIV for the Venezuelan population. We also have first aid program, and also this goes to migrant people. Well, concerning first aid, I can tell you that there is zero information concerning natural disasters. We don't know how to defend ourselves or face any situation that can come up because we don't see these problems in our country. PAHO not only provided knowledge, but also practice with the best tools in simulations. Well, we have had donations to hospitals in Peru from PAHO. This helped us to reach migrants. Each healthcare establishment has a jurisdiction and targets, but these targets are increased with migrants. So our equipment and inputs have to be increased to be able to attend to everybody. So they have helped us a lot in this. This is PAHO that helped us with a donation of biomedical equipment for our Viru hospital. This includes water distillator, binocular microscope, and ELISA equipment. Then this is for both Peruvian and migrant population. We are now better attending to the population thanks to this. Okay, thank you very much. We could see it complete because it's a very good video. It's great because it's a very good video. As I said before, we are now passing to our third panel. I'd like to introduce the moderator of this panel, Catherine Nettleton. She directs the international response against COVID in the UK, and she is ex-ambassador of the UK in Venezuela. She is a diplomat. She has been a diplomat since 1983, the first woman ambassador in Peru. UK woman ambassador. She has knowledge of economy and defense in Latin America. In 2010, she was ambassador for the UK in Venezuela. Be welcome, Catherine. I'll pass you the floor. Please, dear panelists, let us be prudent with time because we are delayed. Thank you for your consideration in this regard. Catherine, you have the floor. Thank you very much. Thank you, Adriana.
Agradecerles la invitación.
I'd like to thank you for your invitation to participate in this event about such a difficult and important issue. The topic in our segment is strategies to drive and reinforce vaccination against COVID-19. and at the same time, adjustment measures to mitigate the effect of this pandemic and access to essential healthcare services.
Contamos con un panel muy distinguido.
We have a very distinguished panel. The members are, and I will briefly introduce them. Alejandra Corral. She is, and I have this in English, sorry.
Ad interim of UNAIDS, Latin American Caribbean. And she has worked for the UN in Venezuela and is now based in Panama. The second speaker will be Dr. Cuauhtémoc Ruiz. He's a specialist in epidemiology and chief of the immunization program of OPS. And third, we will have Yusuf Abdel Jelly. He is the Deputy Regional Director for UNICEF. And in the past, he has worked in UNICEF in West Africa and New York and the Middle East, and is now in this region. And finally, we have Dr. Maria Talarico. She is the head of regional health for the International Federation of the Red Cross. And she has experience in pediatrics, communicable diseases, and humanitarian responses. Bien, sugiero que empezamos.
Very well, I suggest to begin with our first lecturer, Alejandra Corral from UNAIDS. Thank you very much. I'm going to share my screen, if you so allow. I'd like to confirm that you can see it. Yes, we can see it. Well, thank you very much. Good morning and good afternoon and good evening to you all. Thank you for this invitation and the efforts by the platform response for Venezuela and to carry out these parallel events that enrich our work. We have more than 200 participants. I'd like to thank Celso Valverde, who together with UNAIDS co-leads the healthcare sector. Day to day, we see that migratory status and poverty conditions of refugees, asylum demanders, and migrants with health problems have difficult access to health and medicine. I'd like to share some data and something concerning vaccination for people living with HIV in some solutions. First of all, I'd like to frame this in some data, focusing on three important aspects. First of all, the importance of considering HIV in the context of morbidity. Secondly, that access to healthcare services and medicine affect the lives of people, and also access to vaccination among HIV patients is fundamental. Since COVID reached our borders in Latin America, UNAIDS decided to see how this pandemic was affecting our key population, people living with HIV. So we had a first survey on March 17th and a second one in May, and these are the results you can see. In the second survey, you can see some results I shared with you. They were the consequence of more than 2,300 people in more than 20 countries in Latin America, some of which were migrants and refugees. And we started some strategies. We then reached those who had less access, but we reached migrants and refugees. And we found that 40% of people who responded to this survey showed delay in health care against HIV. that was 3 months after the start of this pandemic. No access to treatment. In 13 countries in the region, we started implementing the multi-month implementation. So we gave medicine for 3 months of treatment for those who had HIV. This was implemented in 2016. PAHO and UNAIDS started to do this from the start of this pandemic. Despite the fact that 13 countries started implementing this policy, only 3 out of each 10 people had received more than 3 months of treatment, and only 1 out of 10 only 6 months, despite the fact that it was being promoted, and only 2 out of 10 said they didn't have enough treatment to finish the month. Besides, we also evidenced that despite of this policy, 35% of countries reported that the biggest obstacle for implementing the MMT strategy was the lack of ARV. So the regulation was not enough. We had to emphasize implementation, and we published several guides for this. Lack of ARVs is not only because they aren't procured, but it's also because of a logistic chain problem. So we had to tackle with that too. Now, talking more directly about people who are in a mobility situation, we saw that we had 3 kinds of people. People who had an established migratory status. They had the same limitations as those in the general population. As we have seen in several videos, well, the general population also have problems. They have healthcare systems with problems. Those that restrict migrant people had even more difficult problems. We have data of people living with HIV who have died because of causes related to HIV, and this is unacceptable in Latin America. Latin America has access to treatment. It has cascades that are better than global cascades. Why should we see patients in the 21st century dying due to diseases related to AIDS? This is a greater risk for our key population, including young women and youth, because of the interruption of sexual and reproductive healthcare services, HIV prevention, and prevention of mother-child HIV transmission in a region that should eliminate this kind of transmission. Now, going to vaccination against COVID-19, UNAIDS has a very firm position. Most of you must have seen our executive director as one of the voices in this alliance of the people's vaccine. This wants vaccination free for people, preventing monopolies in vaccination, allocating available doses. We have seen that there are countries that have even 5 times the number of vaccines to vaccinate their population. Some countries do not have even 4% of vaccines for their population. They don't want to limit, they want to limit patients and aid countries in their positions and civil society. But we have many challenges concerning vaccination coverage in Latin America and the Caribbean, and we have had several webinars hand in hand with civil society to touch upon these. Only 2 countries cover migrants. 5 countries guarantee vaccination for those in regular status, and the other countries do not explicitly include migrants in the vaccination programs. However, they are vaccinating them. Sometimes technological access is an important limitation. We should make it visible because many people can't have access. For people with HIV, this is an additional problem because many recent studies show, as from November 2020, that living with HIV there is a high viral charge. HIV is a risk factor concerning a greater risk of hospitalizations, 88% more risk, 23% greater risk of death too. So those living with HIV have to be prioritized in vaccination schemes. A small pause before I show my last slide. We need to learn something from this 40-year pandemic, the HIV pandemic. At the beginning of HIV, we went through similar problems. Treatment was available in 1996, but the price of medicine was not accessible for poor people. 6 years for that. Many million died because treatment was not accessible and not affordable. 9 million people died unnecessarily, and many people will die if we don't learn this lesson, and will repeat history. So how can we achieve this? At UNAIDS and together with PAHO, we have driven the Quito process, and in all the high-level decision-maker scenarios, we insist in antiretroviral therapy in trans-border terms. Our patients have changed their schemes 1, 2, and 3 times as from leaving from Venezuela. And we have to guarantee coverage to migrants and refugees who live with HIV. We understand that thanks to the Global Fund in Venezuela, people who live with HIV in Venezuela have a unique molecule being bought for these patients. So they have to transition to TLD. And this is complemented with actions aiming at responding to COVID together with technical recommendations from national organizations. And we must not forget that to reach access, we also need access to vaccination and regularize all those that are refugees and migrants, particularly those who live with HIV and other chronic diseases, because this is the way to ensure HIV treatment, vaccination, health care, social protection, mental health care, and the right to a decent job that will allow them to become integrated to society. Thank you very much. Thank you very much, Alejandra. You were very brief and quick. Well, now we pass to Dr. Ruiz for his perspective. Thank you, Doctor. Thank you very much for passing us the floor, and thank you for inviting us to participate in this important debate. What we'd like to say here is that since we started facing this pandemic, since we started working with the possibility of having a vaccine, we established global guides to seek for equity in access to vaccines. As from September last year, that is before we had a vaccine, the WHO and the strategic group of experts in immunization established the framework in which vaccines should be allocated and how they should be prioritized. We established that we should work within that framework to see humankind well-being, respect to equality, reciprocity, national and international equality in access to vaccination. Inside that framework, we started to discuss how vaccination should be prioritized. We knew that we would have a limited number of vaccines. Therefore, the strategic group of experts on immunization recommended a roadmap for countries. And they said, well, if we have limited vaccine availability, what we have to seek is to prevent death, first of all. That means aiming at groups where we were seeing deaths, that is healthcare workers and elderly people. Healthcare workers had a #1 priority because they were in direct contact with this disease, and we needed that group of people to be protected so they could attend to the rest of the population. And the elderly, who showed the biggest lethality and mortality rate in this pandemic. The second stage, when having more vaccines, should go to attend people with comorbidities and social demographic groups at higher risk. The third stage, according to the number of vaccines, well, the group proposed to work with essential workers and pregnant women. You can see that this version is from November last year. And obviously, this has progressed along this pandemic, available vaccine doses. And when we talk about social demographic groups, we are talking about migrants and refugees as well. So regionally, the manuals, the PAHO manuals that were discussed with countries in the region stated that we should see what was the vulnerability situation at subnational and local levels, prioritizing areas and people who were vulnerable. Therefore, we should adapt according to the situation of each country, the recommendations of the WHO group of experts. So we should consider the scenario of people who lived in conditions in which they could not comply distancing, hygiene, and other recommendations. People who lived in extreme poverty situations, where there were indigenous peoples and Afro descent population who also had access problems regarding healthcare service, and of course, migrants and refugees. So countries should take all this into account in their prioritization. Obviously, in this session, we have focused very much or fundamentally in migration from Venezuela to other regions, to other countries such as Chile, Ecuador, Paraguay, besides Colombia. Generally speaking, in America, we have migrations, both internally, domestically, in the countries, international, and migration, intercontinental and international migration reaching the Americas. Until Friday, last Friday, 50 out of the 51 countries and territories had already introduced vaccines against COVID-19. To last Friday, 406 million doses had been administered in the Americas. Out of them, 153 million people had a full series. Obviously, most of these doses have been applied in the United States, an important percentage in Brazil because of their large population, but we have 34% administered in Latin America and the Caribbean. The countries that report the largest number of administered doses per 100 people, number of doses, it's not complete series, right? Or full series. Well, these are Chile, United States, Uruguay, Canada, Dominica, and many countries in the Caribbean. Administered doses in the Americas account for 32% of doses administered in the world. As we mentioned before, inequity in distribution of vaccination doses, inequity in access to vaccines have made out for little progress in Latin America and the Caribbean region, despite the fact that we have a great experience in vaccination. We are the region in the world that vaccinates against seasonal influenza in the first place in the world. We have applied millions of doses against this. So what we need is vaccines in America so they can be applied. And that's where we have vaccination policies concerning migrant population and specifically concerning Venezuelan population. As we have already mentioned, there has been a great deployment of support in countries. These are photographs of activities in Roraima, Brazil, where the migrant population was vaccinated against COVID-19. I must say that everybody has talked about the fact that it's very important to have this will about vaccinating migrants. But as our UNAIDS friend said, what can we do with migrants who are not registered? They should also have access to vaccination. Our position is that we have to continue within the framework of values established by WHO, seeking global equity and national equity, reciprocity, and legitimacy everywhere in the world. We need to open access to vaccination for all, no matter if they are migrants or not, and no matter the kind of migrant they are. It is not only social justice, but also public health. We saw this. COVID-19 does not distinguish your migratory condition, your nationality, your gender, your comorbidity condition. Everyone has to be vaccinated, no matter what their migration or nationality condition is, because we need public health. So we have to facilitate access to the COVID-19 vaccine and all vaccines, as Dr. Gross mentioned in her intervention. The immunization program has been very much impacted by this pandemic, and we want to keep vaccinating people. And obviously, all diseases preventable by vaccination will not ask for your migratory status. We have to vaccinate everyone to be protected. So we have to facilitate access to healthcare services and vaccination services, and this must generate coordination among countries, international organizations, and civil society for developing these activities, of course, taking into account a very important point concerning mobilization of resources. This is our participation. I'm here for you. Thank you very much, Dr. Ruiz, for your participation here. Now we have the following participation in our panel from UNICEF, Yusuf Abdel Jelly. And I'd like to remind you, if you have questions, please write your questions in the chat. and we'll have a Q&A at the end of the presentation. Thank you. Mr. Jelly, you have the floor. Thank you very much. Thank you very much, Catherine. And I greet you all. And I observe all protocols and thank you for the possibility of contributing, ensuring access to Venezuelan young boys and girls is a humanitarian imperative. And I'd like to highlight two things from this perspective. First of all, continuing with healthcare, basic healthcare services for boys, girls, and pregnant women. In this regard, measures adopted to contain and control the COVID-19 pandemic has resulted in reduction to access to primary healthcare services, including prenatal care, delivery, and postnatal care, and other services, including psychosocial care. The recent survey carried out by WHO PAHO reported 49% of disruption of healthcare services in the region. More than 1/3 countries in the world also talked about this disruption for prenatal and postnatal care, which are critical to make sure mothers and newborns survive. This situation puts at risk achievements in the last 2 decades concerning mother-child morbidity and mortality. Though we don't have data about Venezuelan refugees and migrants, we are sure that they are impacted even more so than their own host community. Vaccination against COVID-19 now. It is an important part of our response against the acute phase of this pandemic. We need to keep basic prevention measures for a considerable time, though. WHO, UNICEF, and PAHO support governments in technical aid, training, advisory, strengthening cold chain supplies to make sure that vaccines are transported safely, train and inform healthcare workers concerning vaccination, communication actions to fight fear against vaccination. So UNICEF requests governments and partners to ensure healthcare service continuation for mothers, children, adolescents, prenatal care, delivery, postnatal care, routine vaccination, and mental health care, particularly for migrants and refugees. Also, fight against disinformation and foster confidence in vaccination for migrants and refugees, making sure that boys, girls have equal access to diagnose, medication, and vaccination against COVID-19 in a global package of essential healthcare services, including migrants, refugees, and other vulnerable groups as part of national plans against COVID-19. Leaving migrants and refugees without access to COVID-19 will threaten this fight against COVID in the region. Improving healthcare is not only correct, but the smartest thing to do for all in Latin America. Thank you very much. Thank you very much, Mr. Jelly, Abdel Jelly. Now we pass the floor to Maria Talerico. She represents the International Red Cross Federation. Maria, you have the floor. Thank you very much. Welcome you all. Thank you all for this space from PAHO, UN organizations and governments for giving us the opportunity to present our work about mental health care for migrants. I'd like to emphasize what our colleagues in the former panel stated. And also something new. The first thing is I'd like to acknowledge that in Latin America recently, there have been many laws and policies adopted and broadened concerning healthcare services. However, there's a big gap in access to healthcare services and healthcare, mental health care services and healthcare at large, particularly for migrants and refugees, because we have more and more people with mental health care problems, and there's a big gap in resources. WHO shows that only 2% of budgets, health budgets, are aimed at mental health care. In our federation and movement, since 2017, we have adopted a policy and a resolution to guarantee mental health care and psychosocial support for people affected by armed conflicts, crises, natural disasters, migratory crises, or pandemics. And these services are not only for the acute period, they should be continuously and sustainably be there for the population. So I'd like to thank Oscar Perez, who emphasized psychosocial support in Peru in his participation, and also aimed at migrant populations. Also, I'd like to highlight the fact that migration is not a new phenomenon in the Americas. The Americas have 1/3 of migrant populations, and the flow of Venezuelan people has been the largest in the region. 5.3 people of Venezuelan migrants are living outside their country. 80% are in Latin America and the Caribbean countries. This means that this flow in such a brief time has created much pressure in the capacity of governments and humanitarian organizations, as well as civil society organizations, to aid them and protect them in healthcare, mental health care, and others. Our movement has supported with healthcare services in more than 13 countries. In 17 countries, we have 14,000 volunteers and healthcare personnel responding to migrant needs. Under the emergency response, we have provided more than 750,000 healthcare services, around which 100,000 in psychosocial support, a very much required service. And it is added to the services provided by the national societies. We don't have a definite number there. In our humanitarian aid positions or service points, healthcare services, community activities, and different routes in the countries, whether they are in transit or receiving migrants. Our program includes the first psychological aid, dealing with pain, loss, reducing anxiety, stress, loneliness, also building personal skills, positive attitude, and fighting misinformation. Since 2019, we have seen many more women among migrants. 78% of migrants that we attended to in Colombia are women. There are many children too. Many are unaccompanied children traveling alone. And we have a great increase of elderly too. So we have to change the kind of service we provide to the people and evaluate the risks they go through. They have different needs according to ages and culture, gender, sexual diversity, etc. This is why We have included a referral service when there are psychological problems and mental health problems that are severe, so they can be attended by specialists. We have a very good reception in transit and host countries, but we need many more resources to reasonably cover services so that these services are sustainable too. Another important point is the arrival of COVID-19. As all panelists said in their presentations, this has created an exponential demand for healthcare services. For migrants, it's been very difficult to access these services. Migrants have experienced a greater difficulty to fulfill basic needs: water, shelter, a place to sleep, a job, a protection network, essential information to have access to healthcare services, mental health care services, or wash services. Leaving their country is very difficult, even more so when there is a danger for discrimination, being subject to right violation, extortion, etc. This generates anguish, anxiety. In the report of the 2020 movement migration laboratory, 77% of migrants have said that they have very few access to, very little access to healthcare services and mental health care services, and also to basic services, whether in transit or when already hosted. We need to have timely information, involve people, have them participate to be able to fight fear against vaccination, to control rumors and fake news. All this is very important for public health and for the health and safety of all of us. Migrants have also experienced stigma. We consider that transit countries and host countries give them no right to vaccination. We have to change this perception or reality. The National Red Cross Society in Colombia, Ecuador, Brazil, and Dominican Republic have already submitted programs to governments to support the COVID-19 vaccination campaign. It's very important. We lack vaccines, first of all, resources to pay personnel, vigilance or surveillance actions, logistics, a number of actions that will allow indiscriminate access to vaccination. And we also lack mental health care, so the people feel safe, not threatened. So we make an urgent call to invest in this vaccination campaign. I'd like to highlight that we have the commitment to guarantee access to health without discrimination to each group, each vulnerable group without exclusion. When we talk about excluded people and the last mile, for us, it is the first mile. And we guarantee that all migrants, no matter what their legal situation is, must be included in all kinds of healthcare services with equal access. That's our main point. Health is our priority. Mental health care cannot wait. So physical, mental integrity of human beings are important for the safety of all society. So thank you very much for the space. I'm here for your questions. Thank you very much.
Muchas gracias, María.
Thank you, Maria. Well, we don't have many questions in the chat, and we don't have much time either. But we have something that we can ask. Perhaps I can suggest something. COVAX. We haven't talked much about the arrival and distribution of COVAX vaccines and equitable access to COVAX vaccines. Do we have any member in the panel who would like to comment about this point? Thank you, Catherine. Well, the COVAX mechanism, as you know, was generated by several organizations, among which PAHO, Gavi, UNICEF, and other agencies, so we could have equity in access to vaccination. The N1H1 pandemic we had showed us how equity of access to vaccination was important. Several countries in the Americas received vaccination 1 year or 2 years after it started, when it had already finished. So the COVAX mechanism has tried to prevent that from happening. Since we are seeing this great pandemic and the big health channel, the COVAX mechanism is a new mechanism, and it has faced challenges too. It has had problems, mainly vaccine production that had been scheduled by laboratories has not followed expectations. So many countries in the world, not only in Latin America, received the number of doses they required, or in a timely fashion. So well, PAHO is the only organization in the WHO has a mechanism for acquiring vaccines, which is the revolving fund for acquiring vaccines, which is the liaison mechanism for most of our countries in Latin America and the Caribbean. But at PAHO and at the revolving fund, what we want is to facilitate access. We, however, do not partake in the COVAX mechanism decision-making management. There are other mechanisms that allot doses, distribution times, negotiations with producers. We speak for all of the Americas countries in all this process, but it is not a PAHO decision. I'd like to add something here. In face of all this, PAHO has already started through this revolving fund to have conversations with producers to seek to have greater and more timely access at affordable prices for countries in the Americas. This pandemic won't finish tomorrow or in a short time, and we need to get ready to have more doses that are efficient and safe. Effective and safe. Well, yes. Any other comments? Or perhaps I can close? Very well, okay. Well, as a conclusion, our panelists have emphasized several topics we have in common. First of all, the effect of COVID-19, its direct impact is of course very serious, but there are many indirect effects too, and we have to deal with it. The second point, in terms of the migrant and refugee population, civil society, government, international organizations, we all have to insist in having all the people included in access to vaccination. Of course, including migrants and also including migrants that are not registered. Concerning indirect impacts, there are several members in the panel who emphasize mental health care, work being done
HIV
for people living with HIV and children, also elderly population. Dr. Maria Tallarico mentioned that with the change in migration flows from Venezuela, we have many more women and children, as well as elderly people, all those that are more vulnerable among the migratory population. In terms of what we can do to face these problems, Alejandra Corral proposed a regional commission, a transborder action plan, and perhaps other panelists that have mentioned the importance of working together. Several international organizations are active in this region, as well as governments in the region, and the very important role of the civil society in showing where the most serious needs lie. So these are the more important conclusions. Thank you. Thank you very much, Catherine. And of course, thank you very much to all of our panelists. So this is the last stage of our event. Thank you very much to those who have continued with us. And we will see a video facilitated by the International Red Cross Federation and the Red Crescent Federation. And then we'll pass the floor to Ciro Ugarte to close this event. You have the floor. Please read the subtitles. Thank you.
Esos países porque nos recibieron, lo que es Ecuador, Perú, y en Chile también estoy agradecida, a pesar de que pasé por trocha de Perú a Chile. Estoy muy agradecida porque allí trabajé, porque allí pude ayudar a mi familia, pude mandarles dinero a ellos, pude ahorrar dinero para poder venirnos para acá. Pasamos por Colombia y de Colombia, de Medellín, llegamos a Necoclí y de Necoclí nos metimos hacia la selva. Duramos 12 días en la selva. De broma no me morí, pero la selva es terrible. La selva es algo que yo no se lo recomiendo a nadie que pase. Yo tengo un trauma horrible, tengo un trauma, tengo un miedo dentro de mí. Hay veces que me pongo a pensar y digo que como que hubiese sido preferible quedarme en mi país y no haber salido. Pero ¿y si no salgo? ¿Cómo hago con mi hijo?
Sí, muchísimas gracias a la Federación de la
Thank
Cruz
you
Roja.
very much to the IFRC and the Red Cross, International Red Cross Crescent. Thank you to all panelists and moderators for their support, all attendants, Celso Lambaré. Particularly, I'd like to thank him because he co-leads together with UNAIDS, the health group, a great colleague. He and Valeria have had a spectacular work for this event. I'd like to pass the floor to Dr. Ciro Ugarte, who directs the PAHO WHO Department of Health. Thank you very much, Adriana. This thank goes to you as co-leader too. It's a great pleasure to have worked with UNAIDS and all the other institutions, the associations of Venezuelans and the ministries of health of different countries. I'd like to close this event, this so important event, by saying that due to the wealth of everything we said has extended so much. But I'd like to remind you that Venezuela was one of the most generous countries in the world to receive migrants and refugees. Now, during the last years, Venezuelans have been migrating outside their country, seeking for better living conditions. We have listened to direct testimonies, and we know of all those difficulties they have to leave their country. Making that decision is not easy. Transiting different countries that do not accept them so much is not easy. Reaching places where they don't necessarily have the sufficient conditions to work and live is not easy either. However, there has also been generosity and great compensation in several Latin American and Caribbean countries for Venezuelans and migrants from other countries. Welcome, openness, generosity with which countries receive migrants compensate also their contributions to economy, culture, scientific development, and many other aspects in society. So we sometimes think about migrants as a burden. Yeah, truly. And even from the point of view of health, it is clear that this is a myth. It's not true. Within that context, however, the first and last responsibility for making sure that migrants have access to essential services lies in the hands of each one of the country governments, and Latin American and Caribbean countries have responded according to their own services, regulations, and conditions, and they have done so very broadly. We have heard from Venezuelan migrants that they have actively participated in this process. And we have also heard about international organizations that have supplemented support in areas that so require. Looking ahead, it's necessary to even more strengthen this international contribution in areas where it's necessary to reduce inequities and provide destination populations and people in transit with healthcare services and vaccination. We all know that there are more things to do and that there are more people who die and who get sick beyond COVID-19. And sometimes we forget that there are many other health conditions that are not dealt with. During this session, we have heard several times about social programs and healthcare programs that have reduced their capacity and action due to this pandemic. And this pandemic is not finishing. Vaccine availability, the ideal weapon to reach a certain level of protection so as to reduce communication and death, is far months before it comes true, if not years. Scientific development that has led to getting back vaccines in so short time has been made with very large investments, and those large investments are related to countries that have that capacity and that prioritize their population in terms of receiving these vaccines. That's no secret. However, we have called for solidarity. The COVAX mechanism was implemented for that purpose. Despite this fact, we have not been able, as citizens of the world, to have equitable distribution of vaccines, and production is very scarce. We see that AstraZeneca vaccines produced by India, well, you know, India has a very big internal problem. Those vaccines are not leaving India because of their own domestic problems. There have been many generous actions of many countries in Latin America, but I'd like to mention something particularly. This has to do with access to critical personal protection equipment and critical supplies, the humanitarian warehouse in Panama. Panama has never put any restrictions for those supplies that could be used by Panama to be used for the rest of the region. That's an example. In conditions in which equipment, supplies, or whatever went through their borders, they did not restrict. Other countries did restrict. So that's a clear example that solidarity in our region is very big. And I think that solidarity will show in the short term the advantages of working together. And in that process, I think that Venezuelan and other country migrants have a fundamental role. They should not be seen as a burden or as a problem. They are a contribution. Appropriately using that contribution, giving them the element to contribute to our societies is a fundamental principle, our fundamental principles, and only those who do not see this will suffer the consequences of not making the right decisions. So this health workshop, all the participations has been a perfect balance of ministries of health, migrant perspectives, international agencies, and many more that are participating and contributing to this process. Thank you very much to moderators, panelists. We've had a gender balance that has been excellent, and that's another point to highlight in the great work we jointly do in our region. So thank you very much to you all. A special embrace to you all. Thank you. Thank you very much. Thank you all. Greetings. Greetings to you all. Thank you.